Good afternoon and welcome to our Facebook Live event on the topic of breast cancer, brought to you by Neoadjuvant Health and Miles of Hope Breast Cancer Foundation. My name is Brian Powers, and I'm the board chair of the Miles of Hope Breast Cancer Foundation. The mission of our foundation is to fund support services, education, and outreach for people affected by breast cancer within the 9 counties of the Hudson Valley. All the money raised here in the Hudson Valley by Miles of Hope stays here to help those battling breast cancer helping those battle breast cancer through financial assistance, peer-to-peer counseling, complementary medicine, and our college scholarship program for those students whose lives have been affected by breast cancer. So why are we having a Facebook Live event? Our communities often ask us questions about breast cancer. We gathered this panel of experts to answer those questions about breast cancer screenings, risk, what happens if you are diagnosed with breast cancer, and more. We'll be taking questions in the Facebook Live chat. And also, if you're joining us on Zoom and not Facebook, you can also put your questions in the chat feature, and we'll be definitely answering those throughout the event. I'd like to take the opportunity for our panelists to introduce themselves and just give us a little bit of a background as to who they are, their role, and also how breast cancer has affected their lives. So I'd like to start out with New York State Senator Sue Serino.
Well, thank you, Brian, and thank you to the Miles of Hope and Neoadjuvant and all of our doctors that are on today as well. I'm your New York State Senator, but today, more important than that, is I'm someone who had my own battle with breast cancer, and I was diagnosed during COVID. So my message today is really about going out and making the appointment. I had my mammogram in February of 2020, and they saw something and they wanted me to get a biopsy, and then came March and everything got shut down. And thank God in April, I said to myself, and I don't even know what, because we're all so busy, what made me say, oh, I better make that appointment for the biopsy. And I did it. A week after the appointment, I found out that I had DCIS and also found out that it could be an aggressive form of cancer. So I had my surgery by June 2nd, and everything went well. And one of my other messages too is I had never told my mom that I had breast cancer. I kept it from her because I felt like I was protecting her. And I think that probably wasn't the best thing to do. I think the best thing is the more support and love that you have from your family, the best. So that was a lesson that I learned. But I'm interested to hear what everybody has to say today. I do have to jump off in about half an hour for a press conference, but I think Brian will give people my information if they'd like to follow up with me. I always like to talk to people, and any way I can help, I'm here for them. And thank you. I look forward to the panel.
Great, thank you, Senator Serino. We're happy to have you here. Happy you're doing well. I look forward to hearing what you have to tell us more about legislation that's enacted in New York State in regards to breast cancer, and then also about your personal experience. Dr. Susan Boble.
Hi, Brian. Thanks so much for organizing this. I'm Dr. Boble. I am the System Chief of the Breast Surgical Oncology Program and Breast Program for Neoadjuvant Health. My clinical practice is at Vassar. I've been doing this a long time, about 20 years. I feel old every time I say that. And the advances in the detection and treatment of breast cancer are just phenomenal. I mean, it really is earth-shattering what has gone on in that. So I think panels such as this are really important to educate our community. So thank you for getting this together.
No, thank you for joining us. We look forward to hearing more. Dr. Lisa Curcio.
Thank you for having me. My name is Lisa Curcio. I'm a fellowship-trained breast surgical oncologist, and I joined the Neoadjuvant system about 1.5 years ago. I'm the director of the breast surgery program here at Northern Dutchess, and I'm very proud that we took the program from not seeing any breast cancer patients, that we treated over 65 breast cancer patients last year. I myself also am a breast cancer survivor. I was diagnosed with breast cancer at the age of 37 when I had a 9-month-old child, and a mammogram saved my life. So I'm very passionate about detecting breast cancer at its earliest stages, prevention of breast cancer in people who are identified as at high risk, and taking care of the breast cancer patient through their journey and making sure that they feel supported and listened to through the journey. So I'm excited too to be here.
Thank you, Doctor. We're happy to have you here. Happy you're doing well as well. I look forward to hearing more throughout the panel. And then last but not least, Dr. Rashamala, welcome.
Thank you, Brian, for inviting us and putting this together. I'm Radhika Rachmala, one of the medical oncologists here, and I'm the medical director of medical oncology at the Tyson Cancer Center. I've been in the community since 2014, and treating and taking care of breast cancer patients has been my passion from day one. That comes from my personal experience. When I was going through medical school, my mom got diagnosed with breast cancer. Unfortunately, she didn't make it, and she passed away when I was doing my residency. So when we were going through her treatments, my mom once told me, like, hey, why don't you do medical oncology and help patients like us? And that was it. That was the sealing, that sealed the deal. And from that day onwards, and I couldn't be anywhere. I couldn't be happy doing anything more than this, and very passionate about medical oncology. And thank you for giving us this opportunity.
No, and thank you to all of you for being here. We're really it's exciting to have opportunities like this to learn more and ask questions as well, especially now that in the era we're living in, and how sometimes getting together in groups is not possible. We're able to do this here instead. So let's start. Wanted to have kind of a way to go through this in talking about screening and prevention, risk, and then also go over some myths and facts, and then also talk about, if you are diagnosed, what can you expect next? And then also maybe a little bit about survivorship. And I know there are some programs through Nuvance that work with folks on this as well. So Dr. Bobo, maybe we could talk about screenings, who should be getting a screening, what is a mammogram? Maybe start with the basics just for folks that don't know. I know there is some questions around the age of a person to go get screened. Maybe talk a little bit about that.
So it's a great place to start, because that is where we typically start in our investigation to make sure that everything is okay. So lots of controversy and confusion around at what age to start getting mammograms. And it all depends on your risk. And we try not to talk about prevention, because prevention means we are definitely preventing a disease. And rather we talk about risk reduction, because there's certain things that we can do at times to reduce our risk, but we haven't gotten to the point of preventing breast cancer yet. So with the mammogram, we believe that for the average risk women, which is most people, that they should begin getting mammograms at 40 years old and every year after that. And that's called a screening mammogram, meaning you go in for your mammogram, there's 2 pictures taken of each breast, and it means that it's just routine. You don't feel anything abnormal, your doctor doesn't feel anything abnormal, the radiologist is not following up on anything specific. So it's just a routine image, and that's where we start. So 40 years old, and every year after that, again, average risk woman. And that's very important, because if your mom had breast cancer at 40 years old, well, we don't want to wait for you to get to 40 to screen you with a mammogram and potentially an ultrasound. We'd rather do that 10 years before your first degree relative was diagnosed. So if your mom was diagnosed in her early 40s, we'll start screening you in your early 30s. And that's why we say 40 for average risk women, but that may change depending on your individual circumstance.
What I know there's newer technology, there's a term 3D mammography. Could maybe explain that a little bit?
So it's a good question, and it's very important. 3D mammograms have basically become what we consider standard. And at all of our Nuvance sites, throughout New York and Connecticut, our imaging sites only have 3D mammograms. So for a woman or a man, if they're getting a mammogram going in, that should be one of your first questions. Do you have 3D mammograms? Because we want to be sure that all patients are getting state-of-the-art, high-quality care. So when we do a standard years ago 2D mammogram, you took a picture in 2 directions. So you get a 1D picture in each direction, and they sort of tried to combine them in a way to get a 2D look, a two-dimensional look. But remember, our bodies are all 3 dimensions. So where do they get that 3rd dimension if they're only looking at 2 dimensions? And that's where 3D mammography comes into play. And very important, it really should be the standard at this point in time.
Dr. Curcio, just in that same topic, are there concerns that people should have about going for testing? I know it sounds silly to ask that question, but often now in this world we live in with the pandemic going on, what are some concerns maybe people should have about going for breast?
I think that's a great question. And I was actually just going to interject about that. I think what we saw during the early stages of the pandemic was a lot of people were fearful going for their mammogram, and so they delayed. And what we really truly did see is people were being diagnosed with later stages breast cancer. And so Senator Serino, good for you for not delaying, because you could have been dealing with a completely different disease had you waited for another year or so. I think that, a lot of the data that COVID could be obtained by actually getting your mammogram and being exposed to the mammogram machine has been, debunked. And I think that the risks are very, very minimal or non-existent. And so we do encourage people not to delay their screening just because of the pandemic, especially the majority of us nowadays are vaccinated. And I think that brings us to a very safe environment. The other thing that I wanted to talk about that Dr. Bobo touched on is, not every one mammogram is enough. If you have extremely dense breast tissue, certainly 3D mammography is the best technology, but the patient should talk to the physician. And nowadays we do comment on the mammogram report what the breast density is. And if they have dense breast tissue, additional studies like ultrasound can be added to make sure that we're not missing anything, even with the 3D mammography. So I encourage a conversation between the patient and their physician if they need additional imaging, because sometimes the mammogram can be negative and we can find things on ultrasound, especially if the patient has dense breast tissue. And I see that there is a question too, that dense breast tissue can be associated with an increased risk of breast cancer. And so in those cases, we want to be looking at whether or not we should be doing additional imaging and not just mammography.
And Brian, along those lines, I think that this is a good time to thank our state senators, especially State Senator Sue Serino, in that there was legislation passed in New York State requiring that the density of the breast be mentioned on the mammography reports. Previously, it was not, and the patients did not always know that they had dense breast tissue. So now it is a requirement by state law that it is printed on not only the mammography report, but the letter that gets sent to the patient. So thank you, Senator Serino, for that legislation and many other things that you've been involved with along the way for our health and the community's health.
Thank you. And can I just add something too? A few years ago, I supported legislation that would require the large insureds to supply mammograms for women in the age group of 35 to 39 as well. So that was something that was really important. And I think New York really leads the way with taking care of women with the mammograms, even the access to the screening and the treatment through New York Cancer Services program. They are a great place for people to start looking, especially for people that are uninsured or underinsured, because they will supply the access for screening, which I think a lot of people still today do not know. And I know, Dr. Bobo, you and I have had that conversation before, and it's really important to get that message out.
Yeah, it's critically important because screening mammograms save lives, and that's what it's about. So your insurance should not impact whether or not you have a mammogram. And in New York State, it does not.
Yeah, and I know that's a good opportunity to make a statement about Miles of Hope. We worked actually with Nuvance and the other hospital systems to put out that where you're able to get free mammograms and have access to that. So that caution should not be, unfortunately excused.
Right. And Brian, that's an interesting point. Patients talk to me frequently, and I'm sure to Dr. Curcio and Dr. Rashmala about donations. They're very grateful. They've had great care. Should they donate to American Cancer Society? Should they donate to Susan G. Komen? And I just go back and say, what is your goal in donating? Do you want it to stay in your community, or do you want it to be nationwide or international? And Miles of Hope is just such a great organization in our community that takes care of us. It takes care of everyone in our community, and it's a grassroots organization, and you can see the good that your donation does right in your backyard.
I appreciate that. It's a good opportunity too to thank both you and Dr. Curcio for serving on our board and for stating that. But yes, it is a good reminder that what we raise here in Hudson Valley stays here to help those who are battling breast cancer. So at that point, let's move to the topic of risk. So Dr. Curcio, and maybe you could talk a little bit about what does breast cancer risk mean? What should somebody be concerned about? I know we've got some more detailed questions that are coming through on the chat, but we wanted to get into a newer topic, and we will cover those. And we're not ignoring Dr. Rashmala. She's going to come in as well when we talk a little bit about being diagnosed. But let's talk about the topic of risk.
So everyone who has breast tissue is at risk for breast cancer, male or female. But the topic that I think you're referring to is who's at increased risk. And obviously there are both personal factors and family factors. And then there are modifiable factors, like for instance, being on hormone replacement therapy. That's a factor that we can counsel patients and they can choose to avoid. And then there's non-modifiable factors, like what age they first started having periods. So I can run through some of the risk factors for breast cancer. Age is a risk factor. The older we get, the higher our risk. And the age, if you have the onset of your menstrual cycle at an earlier age, that's a risk factor, as well as the stoppage of your menstrual cycles, menopause, at a later age. Birth control pill use is a mild risk factor, but not as high as hormone replacement therapy, especially over 5 years, hormone replacement therapy. Never having children or having first live birth after the age of 35 is a risk factor. Having a family history as particularly first-degree relatives or multiple relatives with breast cancer. A large red flag is having a male member of the family with breast cancer for females and for other males in that family. Having prior biopsies with atypical changes is a risk factor. What am I missing, Dr. Bobo? Have I covered most of them?
The biggest risk factor is being a woman.
We said that.
Right. I mean, that's
smoking, alcohol intake,
And also weight. We know that BMI it has a direct correlation with breast cancer risk. We don't understand the exact relationship, but there is a relationship. And in those patients who get breast cancer, being overweight or having a less than optimal BMI is a risk factor for recurrence.
Now that risk, it's interesting. You don't have the same risk at 30 as you do at 60 or 65. So being overweight after menopause is more of a risk than being overweight prior to menopause. And it's thought to do with the hormonal environment in the body after menopause and the association with adipose tissue or cells, that fatty cells.
So, it's really the things that you should be watching to avoid cancer overall and have a healthy life of, being active, eating healthy, avoiding smoking, avoiding your alcohol intake. But maybe we can talk too a little bit about, because someone asked on the genetic markers. What's the latest information with genetic markers for breast cancer? Are there categories of people that should get tested? And what do the markers mean, and how, what action should those individuals take?
I think the best thing is if someone has a significant family history of breast cancer, i.e. more than one relative, or with the first degree relative with an early onset breast cancer, they should sit down with a physician such as ourselves or a genetic counselor and go over what their risks are and decide if genetic testing is right for them. It's right for some people and not for others. But genetic information can be very valuable because once we know what a person's baseline risk is, if they inherit a genetic mutation, we can help them to reduce that risk, like Dr. Bobo referred to earlier. We know that some of these genetic factors not only put us at increased risk for breast cancer, but sometimes other cancers, which we can also monitor for. So a conversation with a physician or a genetic counselor about what's the level of risk and should they consider genetic testing. Genetic testing is covered by most insurance plans nowadays if you have a family history. And even if it isn't, it is very affordable, several $100s as a cash pay. So cost like it was 15 years ago should not be an impediment to getting genetic testing.
And also,
Go ahead, Dr.
I just
Rashmal.
want to say one point there too. The genetic testing is not only important to like explain or define your risk going forward, but nowadays we have actually treatment, that the modalities that we can use based on your genetic test results. There are certain drugs that are approved. If you have BRCA mutation, there is a drug that's approved. If you have ATM mutations, your treatment plan, especially with the radiation, could be different. So it's a valuable information, not only for the screening, but also from the treatment standpoint.
One of the things I would urge the audience is to find out about their family history while their relatives are still living. So many people live far away from their extended family and they don't know a lot about their family history. The more they know, the more we can advise them on whether or not genetic testing is important to them. But remember that cancers involving genetic mutations are only about 15 to 20% of all breast cancers.
Okay. Now, is there, and I see there are more questions coming through, so we're trying to get to those. As we kind of move to diagnosis, is there a typical time from diagnosis to surgery? I think this is a good question for Dr. Bobo. How critical is it to remove the cancer? Is it possible versus waiting? Are there longer waits for additional testing or any other delays? That was a question that came in.
Brian, I think that's a very important question. Biologically, meaning how is the cancer going to act? It usually is not an emergency. So we have to separate really what's an emergency based on a medical and what's an emotional emergency because you've just found out you have breast cancer. So as you can imagine, and Dr. Curcio and Senator Serino can attest to, those are two very different things. Once you hear you have breast cancer, you want it out yesterday or the week before you even knew it was there. But biologically, meaning how is the cancer going to act? Are we giving it time to grow and spread anywhere else? Most cancers, the overwhelming majority of breast cancers are very slow growing. So there are some tests that we want to do between the time you're diagnosed and first see your surgeon and get to the operating room. So it's usually several weeks. The other thing is sometimes we say, let's not go to the operating room for a variety of reasons, and let's have you see a medical oncologist like Dr. Rashmala, and she's going to start treating that breast cancer right away. And then months later, we go to the operating room. Dr. Rashmala, do you want to address some of those issues?
Yes, so the treatment before starting the surgery is called neoadjuvant therapy. We mostly or predominantly recommend this in patients who present with larger tumors or more aggressive type of tumors. Like Dr. Bobo was saying, this is more of an emotional emergency, but there are certain scenarios where starting the treatment sooner than later becomes very important. Like this is in patients who have a high-risk breast cancer, like what we call triple negative breast cancers or HER2 positive breast cancers. These we consider them as a higher risk. So starting chemotherapy or pills or endocrine therapy or Herceptin or HER2-based therapies early on in your treatment can provide multiple benefits. One is you get started treated, you get treated right away. Two, this allows us to reduce the tumor size, and you can get away with, like if you needed, say, for example, you needed a mastectomy because you presented with a larger tumor. Doing the treatment before the surgery allows the surgeons and us an opportunity to see how we can preserve that breast, how we can get away with a smaller surgery. And the third and the most important benefit we get is we get this prospective information as to, okay, you have point A and I'm giving you this treatment. How is the treatment helping? How effective are these treatments? So we're not playing, dart games in the dark. Here you have a tumor, I'm giving it, I see the effectiveness. And also it allows us to optimize your treatment after the surgery. We can tweak it to get the most of the treatment, most benefit of the treatment modalities out there.
And Brian, that's really where the team comes into play. At Nuvance Health, we believe that multidisciplinary approach for breast cancer really is the most important and only way that breast cancer patients should be treated. So for instance, a patient with, as Dr. Rashmala said, a HER2 positive or triple negative, that's a type of breast cancer, comes in and they see me. I look, and before they even walk into the office, I know they need neoadjuvant treatment. So I've already set up and scheduled that appointment, sometimes in the same day, if not the next day, with a medical oncologist such as Dr. Rashmala. And that's really where that multidisciplinary approach is critically important.
True, and I'm glad you brought that up. And we kind of see that already here today. There were some specific questions when it comes to treatment for Dr. Rashmala about someone had mentioned they understand, and excuse me if I'm pronouncing it wrong, tamoxifen was recommended for stage 0 breast cancer. Is that still the case?
Yes. So stage 0 breast cancer, like Serino had, it's called DCIS, where it is non-invasive breast cancer. It is just inside your duct or inside the lobule, and it has not developed so-called tentacles, so it can get out of the breast tissue. So here, the goal of treatment is to control it locally, so it does not spread or progress into a more advanced breast cancer. So that's where we use surgery, radiation, and then followed by tamoxifen. Tamoxifen is an anti-estrogen. 80% of the times the breast cancers are sensitive to the estrogen levels, or it's modulated by the estrogen in your body. So tamoxifen is a type of an anti-estrogen therapy. Standard of care is still, by guidelines, it's tamoxifen, but there are number of studies using what we call aromatase inhibitors. These are pure anti-estrogens, standard of care. We use these a lot in postmenopausal women. So short answer, tamoxifen, yes, in a premenopausal patient, but in a postmenopausal patient, we can use tamoxifen or we can use the aromatase inhibitors with achieving similar results and not losing any efficacy or benefit or recurrence risk. Sometimes what makes us decide amongst these drugs is not only the menopausal status, but the risk factors. Each drug has a different risk factor profile. So based on how the patient is in front of me, what are their risks and medical conditions, we decide on the drugs, but both drugs are equally effective.
Senator Serino, I know you have to leave us in a few minutes. And I just wanted, just because Dr. Rashmala mentioned you, and that maybe talk just a little bit about your treatment and going through that process, since we're kind of at that point now in the conversation.
Sure. Dr. Rashmala, I was told it was a stage 1. I don't know how much of a difference it is between the 0, 1, 2, 3, but the surgeon that I had gone to had told me that if I even waited a few weeks, what I had could have been an aggressive form of cancer. And when you think about going back to COVID, we know how many people were fearful of doing anything, but the benefits definitely, outplayed any kind of risk factor that you might have had going to the hospitals. And I felt very safe and secure with my treatment. I went to the Dyson Center. Everybody was great. They walked me through the process. It was really a really good experience, and met some great women in the waiting room, talking to them and about different resources that were available. So it was nice. But like I've said earlier, the most important thing is that you make the appointment. I just lost a dear friend who didn't go for a mammogram for a couple of years and sadly went into stage 4, and she's not here today. So
That's a good point. I mean, there's so many resources out there, from a social aspect of support. We have a peer-to-peer hotline through Miles of Hope. And there's research out there, true research from Advanced Health, that you can go and look before you even go to the doctor, just to start to calm maybe some anxieties around that. But Dr. Rashmal, maybe you could touch a little bit about that, the support services that are available during treatment for those that are recently diagnosed.
So patients, as soon as they are diagnosed, they meet with our nurse navigator. She's going to be your key person who is going to literally, with shot of holding your hand and walking you there. So who's going to walk you through all your appointments, starting from the surgeon's office to like medical oncologist's office to like geneticist's office. If you needed a nutrition consult, especially like we were talking about postmenopausal women, not only having a higher risk of, occurrence, but also have a higher risk of recurrence. So if we notice that there are any nutritional requirements, we hook you up with one of our nutritionists. And another service is lymphedema. Like after you have the surgery and radiation therapy, about 10% of the patients are at a slightly higher risk of lymphedema, which is the swelling of the arm of the side of the surgery. So we have lymphedema programs where we have 2 certified lymphedema specialists who work with our patients, and they are even starting to do Zoom appointments, like first appointments with understanding, taking into consideration the COVID restrictions and the scare the patients have of like going into another office, another doctor's office. So they're, even though soon after your initial appointment, they're trying to accommodate patients on Zoom meetings to help you teach how to do the exercises and all. So not only we have supportive systems, we are a team who's made of not only the doctors, but also with the nurse navigators, your lymphedema specialists, your nutritionists, your geneticists who are assessing your genetic risk. And we also have our nurse practitioners helping you through the survivorship program, which starts once you have finished your active acute treatment.
And Dr. Curcio, before we started, we talked a little bit about survivorship and after treatment. I don't know if you wanted to touch on any of that topic as well.
Yeah, I think that, a lot of breast cancer treatment over the past few years, we've kind of de-escalated treatment in a lot of ways. We don't give everyone chemotherapy. Like for instance, if someone was diagnosed with an invasive cancer and they're premenopausal in the past, we would, just kind of go to the side of being more aggressive with treatment and offer them chemotherapy. Now we can do testing on the tumor that allows us to determine whether or not the tumor really benefits from treatment. We're taking less lymph nodes at the time of surgery, but let's face it, cancer treatment causes some long-term sequelae. Some women have to go on endocrine therapy for 5 or even 10 years, and that could lead to a lot of chronic side effects. So part of survivorship is addressing some of those short-term side effects and the long-term side effects, and then optimizing the health of the breast cancer survivor so they don't have to walk this path again, or at least trying to minimize the risk of recurrence or the risk of new cancer events. So it really looks at the whole patient, and part of the survivorship program is working with the patient and their primary care doctor to really optimize their life after breast cancer and get them back to a point where they do look forward to life after breast cancer. I think that's one of the most important things about survivorship.
I just want to add, when I talk to my patients, I try to explain there's a difference between being alive and living. And we want to get everyone back to living. Now, there are some patients that were just alive before and weren't living. And breast cancer is a wake-up call. It's almost like a second chance for a lot of people. It's like, hey, remember me, take care of me, and remember to live life as you're doing it. And that's really where our whole team is focused, in getting patients back to living, not just being alive and going through the motions. It's, hey, stop and look around. It's beautiful. Stop and smell the flowers. Appreciate every day.
And one more thing I also wanted to add was our social work support. So a lot of the times patients, once they end up in one of our offices, they don't know where to go. They don't know, what services are available. Am I going to have to go through this alone based on their personal experiences, or our family, like they might have little children going to school, they might have adult parents that living with them. So our social workers, we provide support in any way possible, and we provide transportation. We have social workers who actually can do counseling with your children or your family members. I often tell patients, if you need me to talk to any one of your family members, just bring them along, or I can do a Zoom meeting with them. So just to look for support everywhere and anywhere you can get, because you're going to need it.
And Dr.
I agree.
Rashmala, that's an important point, because at Dyson, every single one of our newly diagnosed breast cancer patients meets with our social worker prior to leaving the office for those reasons and multiple others. But the support is really necessary.
That's a good point. Oh, sorry, go ahead, Dr. Curcio.
It's okay. I was just going to comment that having that social worker helping with the conversations with family, like Senator Serino really brought up early on, for me, it was really hard to tell my dad about my diagnosis. Actually, I asked my sister to do it. I was just so emotional, and I knew it would break his heart. And having a social worker helping work through all of that stuff, I think really helps to bridge those difficult conversations and really helps us to have those hard conversations. And also just giving them perspective that we don't have when we're going through it, that it's going to be okay, that we're going to do okay from the cancer. And this isn't the end of the story, which when you're in the midst of it, even though I was a breast cancer surgeon at that time, it's hard to know that it's going to be okay at the end of it.
No, that's really good, to know and to have that feedback. And the other piece I remind folks, bring up the social workers, especially with Nuvance, they know that they can reach out to us through Miles of Hope, because when I mentioned the financial help, that is one of them. Even as simple as folks that need help filling up their car with gas. Sounds simple, but folks are out there that need it to get to treatment. We're there to help them, and that's the kind of where we come in on the team approach that Nuvance and the other hospital systems know that they can reach out to us and provide that assistance. As we kind of wrap up, we have about 5 minutes left. There was one question I wanted to revisit with Dr. Rashmala when you were talking about aromatase inhibitors. There's a 10-year recommendation someone had referenced. Are they talking about staying on that longer now?
So right now, the standard of care is still 5 to 10 years. How do we determine that? Based on if you have like a DCIS stage 0 breast cancer, the standard of care is still to use it for 5 years. Anybody with the early stage breast cancer, stage 1, stage 2, or even locally advanced stage 3 breast cancers, recommendations are to use 5 to 10 years. How we determine that is based on multiple factors. But in general, if you're tolerating well, we do recommend 10 years. Beyond 10 years, it's not proven. We don't have the studies to date that show ongoing benefit. And also because there is no medication without side effects, right? So one is, of course, how are you feeling on the, some side effects like little arthralgia, little fatigue that are, these are common side effects with the aromatase inhibitors. And also the longer you take, we have to worry about the bone health, because estrogens, believe it or not, they do some good things in the body too. So they do protect your heart, they do protect your bones. So staying on anti-estrogen medications for a longer periods of time can affect the cardiovascular health and your bone health to some extent. So at this point, I do not recommend beyond 10 years as a routine recommendation for any patient with breast cancer, unless some extenuating circumstances, which are very patient-based. Yeah.
Thank you. And as we start to wrap up, maybe we could go just to the doctors, any advancements or latest advancements that you see. I know we talked a lot about detection and screening and treatment have come so far over the last, I would say 10 to 20 years, but anything new that you're seeing on the horizon, advancements that are coming?
I can start from the treatment aspect. There is, I always say it's hard to perfect the perfection, but we somehow manage to do it. There are just in the course of last year, we have a breakthrough development with use of immunotherapy in patients with the triple negative breast cancers. These are the harder and the more aggressive form of the breast cancers. And immunotherapy is a drug which I'm sure everybody now, whoever watches TV, knows what is Opdivo and what is Keytruda. Everybody knows that, whether you know something. You might not know what Arimidex is, but you would know what Opdivo and Keytruda are. So recently, a study came out showing addition of this to your chemotherapy, especially in the neoadjuvant setting, like if you presented with an aggressive cancer, using this in the upfront improves your survival by about 30%. So that was a monumental development in the treatment of our most difficult form of breast cancer, in my mind at least. And we have other, like using PARP inhibitors, like in patients who have BRCA mutations. Like that's why I was talking about the genetic testing and the implications these mutations could have on you. So if you have a patient who have residual cancer, you've had neoadjuvant chemotherapy, you've had surgery, still there is some risk of this cancer coming back. We can put you on these medications, specifically in that patient population with the BRCA mutations, and can keep you from having a recurrence and improve your overall survival. Like this is in the early stage or curable cancers, and we have a number of drugs that were approved or added to our armamentarium of drugs in a stage 4 breast cancer. So
just to, and thank you, Dr. Rashamala, just to quickly just jump back, because we had similar questions about it. Dr. Curcio, when do you stop mammography? Is there an age that you would stop? Someone asked, is it 80, is it 90? When would you stop going for screening?
So there are some guidelines, particularly that from the task force, that recommends stopping after 75. But I think our American Society of Breast Surgeons and the American Cancer Society recommend stopping when the patient's lifespan is less than 10 years. So it really depends on the individual patients. I saw a 97-year-old patient several days ago that had her screening mammogram, and she's on 2 medications and just one for blood pressure. So that's someone, and she has relatives that lived into their 100s. So I wouldn't stop screening on someone like that. So I think it's individualized to the patient, but if patients have competing medical problems that their lifespan is not going to be more than 10 years, I think it is worthwhile to reconsider whether they should be getting screening at that time.
And Brian, just to go back for a minute to advances, there's incredible treatment advances as far as treating the whole body, as Dr. Rashmala said, but in surgery, we've it's fascinating how we've changed how we do the surgery. I would say I finished my fellowship about 20 years ago, and Dr. Curcio, you probably would agree, I do my surgery completely differently than I learned in my fellowship because we've changed so much. So one of the techniques that we do now, just about on every breast conservation or lumpectomy case, is something called Oncoplastic Surgery. So when we remove an area of tissue that contains the cancer, that tissue does not grow back. And if you just leave it there and you sew the skin back, that's when women get divots in their breast because there was something taken out and nothing was replaced. So we do some technique called oncoplastics, where we're really moving tissue around to maintain the shape and the contour of the breast. Unfortunately, not many breast surgeons do that. At Neoadjuvant, all of us perform that technique, and that really is potentially life-altering because it alters the quality of life for our patients. It really is amazing the difference. The other thing is, thankfully, most cancers are found on imaging, on mammograms or ultrasounds, and we cannot feel those cancers. So we have to have a way of finding them when we're in the operating room, and that's called a localizing technique. Traditionally, and any woman watching this who's had breast surgery knows, you used to go to the mammogram center the morning of surgery, and they would do a mammogram and literally put a wire into the breast, and the tip of the wire would be at the target at what we're trying to take out, and the rest would stick out of the breast. And as you, Brian, I'm looking at your face, it is barbaric. I mean, it really is barbaric. And at Neoadjuvant, throughout all of our sites, we now use a technology called MagSeed, where the woman, anytime prior to the surgery being performed, goes to radiology and they put this very small, what we call seed in, a MagSeed. And when she comes to the operating room, we have a probe, and in the operating room, we use that probe, and when it comes near the seed, it makes a loud beeping sound. So it tells us exactly where that lesion or target is. And we're the only health system in the region where everyone in our health system uses that technology. And it really, it completely changes the patient's experience. So these are some of the many techniques in surgery that we use at Neoadjuvant.
I think the other thing is less axillary surgery. I think we're seeing much less lymphedema, which is one of those survivorship issues, because we're just removing 2 or 3 nodes versus, you know, when we used to do node dissection, 20 to 40 lymph nodes would be removed. So less is more now in a lot of areas of breast cancer treatment.
Brian, can I just,
Go ahead.
I have to jump off for my meeting, but
Yeah.
I would love it if anybody has any questions for me. They can contact my office at serino@nysenate.gov, or they can call me at 229-0106. So I'm
Great.
sorry, I have to
Senator,
jump.
thank you. No, we're going to wrap up as well. So we appreciate all the time you had for us today, and we will definitely share that information as well.
Okay.
And
Yeah,
thank you.
thank you so
everyone.
Thank you, Senator
for-
Serino,
Thank
for
you so
taking the
much.
time.
Thank
for this
you.
topic.
Yeah.
Greatly appreciate this. Thank you.
No, and as we begin to wrap up, I think, you know, really the call to action of sorts that we would leave everyone with is that there really are no barriers to scheduling your screening and going for a mammogram. There are plenty of resources, whether they're financial through Miles of Hope, you know, or just getting that transportation to get there and scheduling it. Neoadvancehealth.org is a resource not only to schedule your appointments, but also to find out more information. And like we talked about before, to start to maybe answer those questions and help with some of the anxiety before you go and visit a physician. But that goes without, needless to say, the 3 physicians that have been on here with us today, your knowledge it was really appreciated, and we appreciate the time that you spent answering questions. I think we got to most of the questions that came through.
One more thing before we close, and it
Yeah.
was just something that you said about eliminating barriers. One of the things that we've done at Neoadjuvant, as you know, typically to get any test in medicine, you need a prescription from your physician. At Neoadjuvant, to obtain a screening mammogram, again, just a routine yearly mammogram, you no longer need a prescription from your doctor. So we're trying to eliminate all the barriers possible in order to make it easier and more convenient for patients. We also have weekend and evening hours to accommodate our patients' schedules.
That's great and great information. Again, like I said, eliminating barriers. I would just, suggest everybody check out newvancehealth.org, milesofhope.org. Both of those are resources for anyone that needs more information or assistance. Those are there. And I'd like, before we get off, to thank both John Nelson and Amy Forney from Nuvance Health for their help in setting all this up and getting it going. I think really it's a good start. We've talked about having these every couple of weeks, and I think this one was a good way to kick that off. So Doctors Bobo, Curcio, and Rashamala, thank you very much for your time this afternoon. We appreciate it. And we wish everybody a good afternoon.
Thank you very much.
Thank you very much.
Have a great day.
Thank you.
Sure.
Have a great day, guys. Bye.